It's my pleasure to introduce Rob Neater, Dr. Rob Neater, the moderator of this session, who is our individual affiliate who joined the foundation very recently. And he brings special expertise about medication, adherence, and lots of experience from running different projects in different countries related to medication management. But I will let Rob introduce himself and then wish you a very interesting session.
Thanks, Mirka, for the introduction. And thanks for the invitation also to be here and to chair a session in an area which is relatively new to me. I mean, I am coming from a background where I try to reduce patients' errors because they don't take their medicines properly or they don't prepare well if they go to a doctor. And that is also something that I would like to bring in as a focus area in the foundation, because today we are talking about, let's say, the second victims. I mean, actually, you are the heroes, and you are not always able to work without flaws, which is also logical and human. If I can have the first slide, please. Or no, I can do that myself. Sorry. Yes. Just very quickly on my background, because I'm totally new to all of you. Originally, I'm a medical doctor, but already for 30 years, I'm working as an entrepreneur, more or less, but I mean, I've retired now, but in doing all kinds of projects which relate to self-management and to patient adherence, based upon the fact that in Europe, between 30 and 60% of patients have limited health literacy or no health literacy at all. And then you can do whatever you say you want to tell patients how to prepare for an operation or how to deal with their medications. But sometimes in the office already they have not understood anything, and many of those who have understood something have forgotten everything when they are back home. So that is more or less my field of expertise. But going back to the subject of this conference, medication errors, I mean, I've learned something over the past couple of weeks, is a very costly and very serious health hazard. I see that from my end, but also from the end of the physician. You need to do a proper job, you need technical support, but if you're not able to implement it right, then it's not going to do anything good. I mean, it's going to give you the stress that was talked about this morning. So I made this little, triangle of terror, where on the one hand there's time pressure, there's a lack of personnel, there's poor interoperability, the systems are not always that usable. This morning we talked about data protection, about security. We did not even talk about liability, but there is so much which is coming in this area which makes it difficult to do a smooth and proper job, the job that you actually want to do, but are not able to do always that easily. Now, that is going to be the challenge of today, to see whether we can come up with ideas or with suggestions or experiences or policies to improve something there. I will give now a brief introduction of the speakers or of the panelists, and then we will try to go through their expertise I will ask a few questions before. They have prepared some slides that they may use yes or no. In the beginning, I would like to keep the discussion a little bit amongst the panelists, but we will try to manage the time in such a way that you will also have ample time and opportunity to ask your questions. Now, to introduce the panelists, in order to not make any mistakes, I will use a little bit of my technology. First of all, in the middle, there's Dr. María Cruz Martín Delgado. She is the president of the Foundation for Research, Teaching and Innovation in Patient Safety, FIDISP, which is one of the organizers of the session, this conference here in Madrid. She's also heading, but as a day-to-day activity, she's heading the ICU of the University Hospital 12th October in Madrid. She has just moved to a new hospital, she told me this morning, actually. And she's an intensivist, and therefore she is surrounded by all kinds of technologies helping her in her work to make the right decisions for the patients. But it's, of course, a pressure cooker situation where you are working in the ICU. And therefore, the question that Maria will try to answer to a certain extent, of course, is how is she able to use these tools, and is there always sufficient time to use them properly or try to learn how to use them properly. The second panelist, the second on the right, for you is Professor Arvid Haugen. He's from Haukeland University Hospital in Bergen in Norway. I think that you traveled around 14 hours or something yesterday. So Arvid did a big job to get here in time. He has lots of experience and also knowledge about the implementation of peri-operative checklists and in supporting patients to become more in charge of their own medication safety. But I mean, even if that would be a successful practice, how can we ensure together that his successful methods reach all medical care units and their professionals and their patients? The third panelist, he is the second on the left, is Mr. Santiago García Blanco. He will represent the position of the patient. He has an extensive experience in digital health and is a member of the Digital Health Working Group in both the Spanish as well as the European Patient Forum. And he will try to explain to us how he sees, from the patient perspective, medication benefits deriving from technology. Then the fourth panelist is Eleonora Varntoumian. She is sitting on the right. She is a policy manager at the European Health Management Association, the EHMA, in Brussels, who is also very much engaged in the organization of this conference. Eleonora dedicates herself, and I have the feeling completely, to bringing policies and strategy proposals on better patient management to all kinds of European institutions. So that's the European Commission, but also all kinds of other important people in Brussels. The question, of course, is, do the bureaucrats and the politicians who are working there and who are working for us, do they understand what is required? And she will say something about the work that she's doing there. And finally, all to the left of you is Mr. José Luis Gomez. He's the Vice President, Public Policy and Advocacy for Europe, Middle East and Africa of Becton Dickinson, a major health technology company, with a lot of experience in the implementation of technologies to enhance medication safety. But the question, of course, is, and hopefully we can use his experience, or learn from his experience, how to implement that successfully and what are the critical learnings. Now, let me sit down and use this microphone, if it works. Is this microphone working? Sorry. It does, okay, great. Because then I would like to open our panel discussion by asking a first question to Maria. And that is whether you can share your experience from the ICU with regard to the severity of this issue of medication errors in the patient that you have, and how technology is helping you or making your life sometimes more difficult.
Thank you very much. En el ámbito de la medicina intensiva ya hemos visto durante las anteriores ponencias cómo los eventos adversos afectan a un número muy importante de pacientes. Los pacientes críticos son pacientes especialmente vulnerables y los errores de medicación, uno de los errores o eventos adversos más frecuentes y más graves.
Most often and most serious errors in our intensive care units. That's real for different reasons. It's critical patients by definitions who are serious and non-stable patients with more and more comorbidity that we subject to techniques which are more and more aggressive. That, together with the high number of medications that they get, many of them are high-risk medications. That means that we face a situation where these patients may suffer from many adverse events. There's many publications that prove the impact of medication errors on patients who are critical, but we also have data from our environment in Spain in 2013, one of the studies that is the largest ones on errors of adverse events in general, and 25% of these adverse events were related to medication, the majority of which is related to prescription and the administration, and there's also a high percentage that led the patient to damage. But out of all of the data that we may find in the literature, most of them coincide on what is most significant, which is that assessed by the professionals themselves, doctors and intensive care nurses from more than 70 units or wards of intensive care units, more than 80% of these adverse events could be prevented, medication-related errors, and that means that we professionals need to act, need to look for a way to reduce all of the adverse effects and specifically medication errors. There's many factors related to this type of adverse events. As it happens in all adverse effects, we always have many contributing factors. And those factors, there's many solutions that might help reduce or mitigate the damages. And technology, which is the aim for this presentation, is one of them. Our environment in the ICUs is highly technological, and that has helped us improve the prognosis of the critical patients, but that may also lead to other errors that are related to the introduction of this technology. There's literature, there's scientific evidence, although I believe that not sufficient, and we need to have more studies that prove the seriousness of how introducing technology, specifically in the use cycle of medication in our units, would reduce the medication errors. We have studies that have been published in different fields: electronic prescription, systems of support to prescription, automatic dispensers of medication in the intensive care units and in the wards, and other examples such as intelligent or smart perfusion pumps reduce the errors of medication. And all of this, somehow, if we use it as measures of packages, could, in a synergic way, reduce these types of errors. I think we're going to talk about traceability systems also, but really the technology has proved that in other fields it does reduce the medication errors. And even if we still need more evidence, I think we need to work on trying to prove how this technology can help us professionals.
Thank you very much, Maria. Maybe just one additional question in following up, and that is, how can technology reduce really the problems that you are facing? How can you be helped by technology? What are the, let's say, the criteria that you're looking for?
Technological tools that can help us reduce these errors. What we need is for these tools to be integrated in the workflows. Oftentimes we do have those tools, but they're isolated and they do not contribute a whole solution. It's as if you had a high-range car that we don't use as such, but in a very isolated manner. We need everything to be integrated, and that requires interoperability of the entire system. So, as we said, that when we start thinking about prescribing a medication, until we really administer it and it is documented and recorded in the clinical record, all of the tools that we have and that could be used technologically are interconnected so that we can do the monitoring and the follow-up of the flow of that medication within the intensive care unit, such as it is done in other fields. Beyond healthcare, outside of the healthcare world, we have clear examples of how technology allows us to do the monitoring of other interventions. But we still have not taken it to the intensive care units or to other healthcare spheres. No doubt, I think, technology can help us. But we need to see how to introduce that technology within the organization, because it does require to have a global vision of safety. It needs to have also included economic aspects and how we can interact with the technology itself.
Okay, thank you very much. I mean, there will probably be questions, but again, I try to save them for the overall discussion. Now, you are talking about the situation which you are faced with on a day-to-day basis with patients in the ICU. I mean, many of them come from the operation theater. So I would like to ask Arvid, who has a lot of experience there, how may patients be stimulated or be supported by preparing themselves better for the operation theater?
Thank you. Yes. First, to answer your question, I need to tell you about a project that we have performed in Norway. Some years ago, I was approached by patients because we had done a lot of work on surgical safety checklists. And they challenged me and the team to develop a checklist, a tool for the patients that could be used for before they come into surgery. So we developed a tool. They wanted it, the patients wanted it to be a checklist, but we also added instructions on each item. And together with the patients and the healthcare staff within the wards, the surgeons, the ward doctors, the anesthesiologists, the pharmacists, the nurses, and everyone involved, also the GPs, we identified the risk areas of patient harm within the surgical pathways, and for across different surgical specialties. And also we looked upon some of the risk areas was within medication safety. And we believe that patients could, by being kind of targeted with information, they could have a better health literacy, or we could stimulate, empower their own actions. So by using the checklist, we wanted the patients to take action themselves, not let everything be leftovers for the professionals, but also have a kind of an awareness that they could do something, be involved in a better way. So before they came into hospital, they received this checklist. This is the paper one. We also have a digital checklist, which is more maybe complicated, or for some more easy to use. But the medication, we wanted to ask the patient, are you using medications? Why do you use it? What is the name of the drugs that you take? Why do you take it? And when do you stop using it before surgery? The blood thinners, for example. And especially if they have a medication list, is it updated? If not, go to the GP and bring it with you, and things like that, because we wanted the patients to be involved as much as possible. Also, before they went home after surgery, they could also have information from the doctors or the nurses about the new drugs, when to stop and using it, and who to contact if they had any problems. So, so this is an innovative tool that we want to actually spread across the board, because we believe it is important, and we are doing a trial now to see the effects. So we don't know the answer yet, but the experiences from the patients is very positive. So if you scan this, you could find the study where we developed the checklist. But if you take it into the operating theater, I've also been working within operating theaters for since 1997, and as a nurse anesthetist, and we also report medical errors. And on medication, I just found some data from our hospital, and we could see that is a lack of double check is one of the main causes. Also doing a wrong double check when you prepare the medication, that's also an issue. And when you administer the injections, we switch remifentanil, propofol, we give saline or Curacit, suxamethonium instead of saline, and diverse problems that happen. And I think these are kind of things where the patients may not be involved in the things happening. They're not responsible for this, of course. We have to look at how we train the nurses and the doctors, and how we can use technology to prevent these errors from happening. And maybe there are some, I can see David here, he's very concerned about using syringes with, which is pre-filled. And you may have a barcode, and maybe you could use technology to scan it before you give it to the patient, so you can have a warning, this is Curacit, this is opioids, whatever, and you know what you are administering. So maybe I hope that we will have some more help from the medical technology on that one. Yeah.
Okay, thank you, Arvid. Now, we have heard something about the difficulties in the ICU. We have heard about Arvid's efforts to, to involve patients better, to prepare them better. Now, what I'd like to ask Santiago, representing the patient, I mean, how does the Spanish patient forum, how does the forum stimulate actually patient safety within the Spanish society? Can you say something about that?
Yes. Well, first of all, I'd like to thank the organization of this Congress on behalf of our President, Antoni Lorenzo, which could not be here today. And thanks for helping us to bring the voice of the patients to this table. Well, the Spanish Patients Forum is working for a lot of years now. It's 20 years old. We have a lot of history. And it's working in patient safety because patient safety is one of our main worries. Okay, and we would like to thank specifically the Spanish Society for Healthcare Quality, SECA, which is one of the organizers of this meeting, because together we were able to launch 2 years ago the Alliance for the Patient Safety Against Medication Errors. This is an initiative that comes from the civil society that has received a lot of support from a lot of healthcare professional associations and societies, scientific societies, and it's a kind of lobby in the better sense of what a lobby can be, okay, to influence politics, influence healthcare organizations, to get that patient safety is a priority. No? And of course, this manifest has 5 or more, let's say 5 areas of action or call to action, which are regulation. The regulatory part is very important. We need a law that addresses patient safety, and this has to be not only a national law, but has to be accepted by regions, which run healthcare service here in Spain. And it's very important also the reporting of adverse events. I mean, we have, I think it's been addressed today here, the Spanish system SINASP, which is, I think, a success story here in Spain, which this system allows professionals to report adverse events, but anonymized, in anonymized way, so the organization improves, but no one is guilty, or blamed for it, okay, for the error, okay. We work together to make things better. Training and awareness is the other one of the pillars of this manifest, okay. Training and awareness both for healthcare workers and also for patients, okay? and also for managers, top management of healthcare organizations. And finally, and which is the area where I was responsible, I had the opportunity to run the IT department of the Cantabria Healthcare Service, to have adequate human and technological resources, both in the financial sense, and also we need more heads in the IT department to run everything that is needed to put patient safety as a top priority in the healthcare service.
Santiago, you are a former CEO of healthcare services in Spain, and what do you think is the missing in terms of financial resources, strategies, and personnel to ensure correct and complete digitalization of medical prescriptions and administration processes within the hospitals? Yeah.
I would say the main problem, or the biggest problem, the biggest challenge is that IT expenditure is still not a priority. It's something that is viewed as an expenditure and not an investment, which is the main problem. And for example, you can find a lot of healthcare organizations without the role of the CIO. A CIO which sits in the steering committee and is able to solve problems with technology. But a lot of healthcare organizations still lack this figure in the organization, and without this, it's very difficult to put solutions on place, on the table. Secondly is investment, or the level of investment. In Spain, for example, we measured this throughout the Spanish Society of Healthcare Informatics, and it's about 1.6% of the total healthcare service system expenditure. That is too low. That is too low for the digital transformation that is needed. I mean, if we compare us with the banking sector, for example, or the transportation sector, I mean, yeah, and indeed it's crazy because with that low amount of money, we do a lot of things. We do a lot of things in interoperability. There is another problem, which is the lack of standards. I mean, there are standards, okay, but they are very young in terms of implementation. For example, there's a lot of hype, and we're talking about open EHR. Open EHR is, it could be the solution, to our problems, but for the time being, many, or I would say majority of the vendors of the electronic health record application vendors are not using this. I mean, they are using proprietary data models, so it's a challenge to interoperate between healthcare levels and between different providers. And the last point of my contribution would be, María has mentioned it, is human factor in healthcare. I mean, to make applications usable and to avoid human error. That is one top priority, should be one of the priorities for an IT department in healthcare. Thank you.
Thanks, Santiago. Now you are both working or both active at the Spanish level patient forum as well as the European level. And I just take for granted for a moment that what you have been saying about the problems or the issues in Spain are very similar to what is also the case in Europe. And that brings me to Eleonora, because Eleonora is working at the European level. Maybe you can elaborate a little bit about how your organization, EHMA, together with the EPACT Alliance, how you are working at the European level to improve issues around medication safety.
First of all, thank you so much for organizing this event, which is coming in such a timely manner, especially right now we're talking about the appointment of the Commission, the Parliament, so it's more than critical that these topics are raised right now with the new Parliament and Commission. So we shouldn't take for granted that when we talk about health, this is a continuous effort to keep it high in the agenda. I don't even need to tell you about the geopolitical issues we are facing, energy crisis, environmental policies, so it's becoming even more critical. So EHMA, representing health management, bringing together all the ecosystem of hospital managers, pharmacists, patients, regulatory bodies. When we decided to conduct a project, so in 2022 we formed an alliance of 23 NGOs based in Brussels, which you can understand that they have an even bigger impact when it comes to member states. So we came together to tackle some of the most critical topics, including now there's a discussion about the revision of the pharmaceutical strategy. So looking about the medication, which is process, which is the topic of today's discussion, but also digitalization and also the European health data space. So what we did here, learning also from the COVID-19 pandemic, one of the biggest questions in Brussels that came up was why industry should stay in Europe and actually fund when it comes to safety, when it comes to medications and so on. So reviewing this pharmaceutical strategy, we proposed some amendments. So we gathered 23 organizations. We wanted to make sure that they represent what people working on the ground actually want to shape in these policies. So as we were looking into the topic, we had some successful amendments. This is a legislation that is already in process. For example, we interviewed the European medicine agencies and the national competent authorities about medications, and we realized that there is no visibility of stocks on real time in hospitals. So this is very tricky. Similar to how on an individual level you should know what medications you have, it's very critical to have that in the hospitals. So the proposal that we had here was that the establishment of infrastructure that we mentioned also today's morning, to have a European medicine shortages portal where each hospital manager can go to report these medicines. By doing this, we make sure that the Commission, when there's a next crisis or even on our daily operations, we can make sure that the patients receive the right medications when they need them. At the same time, we also looked into the topic of strengthening when it comes to community healthcare. We realized that pharmacies, when it comes to inventory, they had to step in a higher role, especially during pandemics. So it was also very important to make sure that pharmacists, hospitals, and the government are connected. And when there's an issue, this reporting of the Commission and the European level, we can step in to have some mitigation plans. So other amendments was the EudraVigilance database. So here is where you report medication errors. So it's a tricky topic, as you know already. So admitting that you made a mistake, it takes courage, as we mentioned during this morning. But it also has to do about making sure that these are recorded, to make sure that there are the right systems in place. And having this data, we can make also more informed decisions, also from the policy side of view, but also for the people working on the ground. Another topic was also, we incorporated, which is, I think, another innovation kind of point of view, the introduction of single-use dose barcodes for medication errors. So practically what we are doing right here is to track the medication care pathway. And by tracking, we can have all this data that we are needing about the effects of medicines, making sure that the system is interconnected, but also we need to also look into other aspects, of course. Following up all this work that we did on amending this pharma strategy, what we did was to send a letter to the European Commission, which was calling for a European patient safety strategy. So this is huge, because we know there's a big fragmentation when it comes to member states on patient safety plans. This was also included in the revision of the pharmaceutical strategy. Actually now, member states need to create these plans. And here I have included the 7 key asks, so we need to have a more unified approach when it comes to this topic. We need to allocate finances, because countries like Spain, Greece, Italy, smaller countries need to have the financials for the infrastructure, for the skills, but also to make sure that the system is implemented in hospitals with support also to regulatory compliance. Another topic was also to make sure that we address also, as we mentioned, the needs of the workforce. So training is also a critical point of view to make sure that we don't create this digital fatigue as well. And to also have investigating frameworks, which was some of the ones that I mentioned previously. So if there are any medication errors, this should be reported and monitored at the EU level so we can step in. The great news was that, imagine right now with all the things that are ongoing, when we sent the letter around April or May, within 2 months we received a letter from the Commission, actually from the Unit of Health, saying that, so practically when a commission finishes its term, which was during the elections, there's a new commission now taking forward. And during this transition, there's a legacy document which outlines the achievements of the previous commission and what they would like to see in the strategic agenda for the next 5 years. And the letter was saying that this has been, we are very grateful for this topic. We had, as you can see, 13 organizations endorsing this letter, and this topic will be open to discuss it with the next commission. So for us, of course, the work is not done. This is exactly, it gives us the base to go now to the new commission once they are established to open up again this discussion. And I would like to conclude by saying that all this work, and especially organizations such as EHMA, the added value is exactly to have these alliances. When you have an alliance of stakeholders, you know, with the constraints we have in financials, especially if the Commission wants to put a strategic plan on something, it needs to be benefiting multiple sectors, economic, social, humanitarian, and so on. So by building this kind of alliances, including patients, researchers, clinicians as well, then we can make sure that we are addressing not only the needs of the people on the ground, but we actually make a good use of the resources that we have in place.
Well, actually, that sounds very promising. I mean, I have been involved separate, I mean, from a distance, but in 2 or 3 European letters, if you will. But I think that all the people that were involved in that are still waiting for the answers, and that is already years ago. So the fact that you got an answer is a very, well, that is a very promising thing, right?
Exactly.
Yeah, very good. So now let's assume for a moment that indeed the European Commission is going to put the necessary resources in order to help strengthen patient safety and especially medication safety, where technology might come in, but technology has also its drawbacks. So that brings me actually to José from his from his experience at Becton Dickinson. What are the most, from your experience, what are the most important do's and also don'ts if you talk about new technology as the savior of the problems that we are discussing here?
Thank you very much. Yeah, let me first talk a little bit about the resistance. I mean, patients were talking about why technology is not implemented today, and I fully agree on the comments. I mean, one of them is human resistance to change. I mean, even nurses, doctors, even if they see a new system, but this change the way they have been working for the last 20 years is always difficult. So workforce crisis is another one. I mean, less healthcare professionals on board, so you have to train them on new systems, new technologies. They don't have time. I mean, so it's another burden, so it's a difficult barrier. As well, the investment, I mean, money. You have to invest money. IT systems, as it was mentioned, is not recognized as a critical one, more expense instead of investment. But as well, investment in medication errors prevention is not sexy. I mean, compared to a surgical robot or high technology. I mean, it's not one that maybe the hospital is looking for to be in the news and to get a difference versus other. And the other one, we will come back to that later on, is around accreditation process. There is not too many or too much accreditation process, and this is all standardization, and this is an important one. You will see that the European Union is working on that in cancer, and this can play a significant, or drive significant change in the future. But coming back to your question, I mean, technology is as well sometimes responsible of low penetration or implementation because the technology is not the right technology. I mean, for example, you can see there it's complex or requires a lot of IT skills. It's not intuitive, or at the end, healthcare professionals have to work more. It's not solving the burden, it's creating more burden for them, or they are driving thousands of more alarms and they are fed up of alarms, or they are, instead of reducing errors, they are increasing errors. And the other important one is the interoperability. Well, this is This is every day in European Union, European Commission, Parliament, they are talking about interoperability. They are working on probably one interoperability directive. But it is critical for healthcare professionals to work in just one system versus having 10 systems and moving from one system to the other. I would like to show you one example of how a technology can minimize medication errors. And before I would like to ask you a question. I mean, many of you were flying to Madrid, and I'm sure you had in your mobile phone your 2D barcode with your boarding pass. So you used them to get access to the airport, then before getting the plane. So how many hospitals or how many units you see that a nurse is reading the barcode in the bracelet of the patient, the barcode in the medication, checking that everything is okay, and then administrating medication? This is not happening today. It is not happening in general. Well, for example, in aviation, which is, I mean, it's happening, and in many other areas. You know, so why this is not happening if there are technology? And this is a little bit the technology that exists today. I mean, María Cruz was talking about electronic prescription, electronic preparation, and electronic administration, or what is called BCMA, or barcode medication administration. So these systems are interoperable, connected to the electronic health records. They are easy to use. They are eliminating all the burden for healthcare professionals of documenting what they are doing, because everything is documented automatically. In most of cases, the only thing you need is just a barcode reader and check your pad to check that everything is okay. Again, they are connected with electronic health records, and they are really minimizing a lot medication errors. Not terminating with them, because, I mean, professionals can overpass the systems in any case, but they are minimizing errors. And they are well established in oncology in general, not in all European countries, but in general, many centers, especially, for example, in Spain, there are many centers that have this technology. But interestingly, European Commission, as you know, through Europe's Spitting Cancer Plan, which is the big plan on cancer in Europe, one of the pillars was the creation of the European Comprehensive Cancer Centers Network, ECCCN, or whatever it is. And they have already published the standards. I mean, if a center wants to be part of the network, of the club, they have to meet some standards. Unfortunately, in 6.2.10, as you can see, there is the mandatory use of an electronic prescription and administration system connected to the electronic health record. So this is amazing. I mean, this is a significant step for patient safety and medication errors prevention, at least in oncology units and as well in oncology medication administration. Now, this technology is moving to ICU units, as María Cruz is saying. Still, there are a lot of studies. More is required to demonstrate that these systems are reducing medication errors. There are a lot in oncology, but less in ICU, so more to come on that. And just to finalize with this slide as well, I mean, alarm fatigue. I mean, in an ICU, and María Cruz is an expert on that, I mean, there are so many pumps, infusion systems, that are sending alarms continuously. So this is creating alarm fatigue, and the problem is that healthcare professionals do not pay attention sometimes to the critical ones. And then patient safety is at risk. So today there are already systems that can connect these pumps in a central unit, deliver information to the pad of the healthcare professionals. So this is really reducing alarm fatigue, reducing medication errors. And another important thing, as you know, pumps, they have like a safety system to avoid mistakes when they are programmed, because of library of medicines are changing continuously. The system is not used because, I mean, you have to change manually all the pumps, and this is not happening. So this safety system is not used in the pumps in general. With these systems, you can change the library from a central computer to all the pumps in the unit. So this is really helping a lot safety in the IC unit. So these are just examples of good technology. I mean, reducing errors, but as well reducing burden, reducing alarm fatigue, et cetera, et cetera. So it's for the future.
Well, I mean, actually, In that sense, the future looks good. Also from the European space, I think the future looks, in any case, positive. But I mean, I'm not in your area of expertise, and what I find terrifying is that all these, let's say, improvements need to be put in place while your shop is running. I mean, you have this interoperability problem. Now you can solve it by throwing away all your systems, but that's never going to happen. So I have big respect for the problems that we are discussing here, and that we should all be looking out for improving. Now I hope that with the panelists' contributions, you got a relatively good impression about what is, what people are dealing with regard to medication safety. So I would like now to offer you the opportunity to ask your questions to our panelists. If you just raise your hand, then you will get the microphone to you.
Yes, Prof.
To the
well, no. Just,
oh.
Prof, just one thing,
sorry,
talking about this point. I can assure you that the pharmacy department of Valdecilla is the worst customer for IT, because as you mentioned, it has to work 24/7, no errors allowed, and every change needs to be tested and tested and tested before going live.
Yeah.
Mm-hmm. Thank you. I'd like to thank the panel and congratulate the panel firstly on a really important topic and some really fantastic innovations at both national and European level. But I wanted to ask a question about capacity to improve. When I remember my old healthcare professional days, which are now a little bit of a distant memory, one of the reasons why things didn't go well is because people were rushing around, trying to deliver urgent healthcare, being constantly interrupted by a more urgent patient than the previously urgent patient you were dealing with. And so whilst a number of cognitive tools and reminder tools and cross-checking tools can make some difference, do you think that we still have, especially post-COVID with the recruitment issue, a capacity problem at a human level that may need to be raised by you and championed by you as a complementary component? Or do you think that's now not an issue? Because actually what you're going to introduce will compensate reasonably well for the workload issues. I'm just not sure, and I'd love your advice.
Is that a question to José or to María?
Well, actually, it's to everyone who might have knowledge of what it's like in the real world.
Well, that's a very interesting question or comment. Generally speaking, professionals would agree that human resources are not enough, oftentimes. But we want to have the optimum conditions to act efficiently. We waste too much time in inefficient endeavors that do not contribute to reduce security problems. Of course, we lack personnel. We lack human resources. I don't know how to convince people and managers to hire more. It's going to be very difficult, but so until then we have to work and redesign our standard procedures so as to gain efficiency. I'm sorry. There are other experiences like Link that when we assess the processes too many times, we dedicate time to things that do not contribute value.
I fully agree with what you were saying. And today the European Union, Belgian presidency put this in the agenda, the workforce crisis. Nothing happened. It is not in the agenda of the future healthcare commissioner. Well, it is included, but not a lot. But this is going to come soon in the European Union. But I think the solutions in terms of more healthcare professionals are going to take long. So the program probably is going to split in first how to increase healthcare professionals long term, but in the meantime, what can be done? And improving processes and technology. Technology is really one significant driver of driving efficiency for healthcare professionals. And just for example, the technology we have discussed, I mean, electronic or digitalization of medication management, studies are showing that for pharmacies, they can produce approximately 30% more medication with the same resources. And nurses can administrate 40% more of medication with the same number of nurses. So this is efficiency. I mean, it is true, we need more healthcare professionals, but in the meantime, this is a good short-term solution. But for sure, long-term, something should be done, and we hope that the European Union is taking the lead in some months' time.
Yeah, that would be... you want to say something about it? Yeah.
Yes. I think in terms of capacity, this is the #1 question that we have and the most challenge, because these are great ambitious plans. But even if I go out today and I speak to a hospital manager and I say, you need to put this into place, the first thing is that I don't have the capacity and I don't have the funding. And this is exactly the shift of mind that we need to see the long-term values of digitalization. Of course, we do not expect people to hit the ground running from day one. It's a process that will take a lot of years. And having this thought, also talking to our members when it comes to the annual conference we organize every year, we decided to also, we are writing right now an how to digitalization of hospitals medication management guidebook. And this is a step-to-step guides from all the factors, all the barriers. How can you address them? How you can access financial resources? How you can make sure that before going to a full implementation, there's also this system down, which is a bit dangerous as well. So moving into partial implementation of digitalization and then processing to other units. But I want to be a bit optimistic as well, thinking that, of course, it's challenging, and of course, it's going to take a lot of capacity to do it. But at the end of the day, we need to realize that with the increasing number of patients and all the challenges that we have to do, we need to move to this direction. Of course, not at the expense of the people, but driving the people with us.
I think your question said...
If I could just say as a quick response to that, lovely answers. Digital transformation is, to me, a way of meeting the capacity crisis halfway. You know, we can help reduce the level of stress in the lack of capacity by making our people much more effective and much more safe through digital. So thank you.
Arvid, you want to say something?
Yeah, I was thinking about the implementation of solutions, and implementation is a challenge across the board, and also the professions that we do have kind of autonomies within a hospital, and in my experiences, it's kind of a challenge to do implementation, because we don't want to handle new things. We want to do things the way we always have done it. So having implementation strategies and doing this on a systematic level is required for the implementation. Yeah.
Are there another question? Yes.
I would like to thank you all of your contributions and your visions of what is going to happen. But I would like to know from the European perspective, if the Commission, the European Commission, has a real good understanding, and which understanding does it have for what is patient safety? We all talk about patient safety, but I believe everybody has a different understanding of what patient safety is. I see it with I'm a doctor, I see it with my colleagues from different disciplines, I see it across Europe with different countries. And are we always talking about the same topic?
That's another tricky question that we're facing also when we're discussing about the EU policies. I think the #1 resilience that we had for many years is whenever we brought up a topic of health, we would always get the reply, it's a national competence issue. It's not up to the EU to decide. So this was the excuse that we, for many years when we talked about safety or any other issues, that was the concept. With the COVID-19 pandemic now, member states are actually more open to this. We have actually the health union concept. So similar how we have economic and social policies, we will have this concept of the health union. So member states are pressured, in a sense, to sit around the table to tackle this, because they know also for smaller countries, if we have the next pandemic, which will happen within the framework of time, member states will not be ready to cope. And usually it's going to the Commission last minute to ask for help, but then bigger countries, Germany, Nordics, or France, they want to tackle these issues internally. So I think what is important here is to keep this kind of pressure. As I said, health was a very strong, we had the Europe's Beating Cancer Plan, we had the NCDC initiative, we had great ambitious plans, but because COVID was there, people tend to forget. That's the other challenge. We had a lot of finances, EU4 Health, one of the biggest finances, and now we're talking about budget cuts because we're talking about security and other topics. So I think it's becoming even more pressure, to put a lot of pressure to talk to members of the parliament, making sure that they understand what it is. And then when it comes to national patient safety plans, as you say, it also has to do with the demographics, the different needs of people. We are, for example, EHMA is a member of the Critical Medicines Alliance, and we're talking about critical medicines. It's very hard to agree with 27 member states what is a critical medicines, and I will use the basic example, vitamin D. For those living in the central part of Europe, it's critical, for the south, it's not. So how can you agree what is critical? It's this exact mindset. So it's about all these organizations, umbrella organizations, to keep the pressure. We're not hearing good news from Brussels capital, let's say it, about health because of all the things, but I think exactly because there's this challenge, it's a moment to keep this on the agenda. It's not gonna be easy. You will always have member states wanting to tackle these issues internally, especially if they have their financial resources, then of course, you know, it's a bit of an ego game as well, and political game. But I think this should not stop us because I'm telling again that the next pandemic is in our door, and if we don't invest now, we won't be ready for it then. So the content of the patient safety plan is not something of a European patient safety plan, might not be easily defined, but we can agree on some minimum standards, similar to how we're doing for our other files.
Just a comment as well on that. Patient safety does not exist. It's like in a black hole in European Union, in European Commission. I mean, several initiatives have been launched on that. No way. Last one is EHMA one with this open letter. Let's see, it's not included in the list of items that the new commissioner, if it is finally appointed, has in the agenda. So there is no even discussion, I mean, it does not exist. So the interpretation, there is no question about what they interpreted about that because the words do not exist. And one good example is Europe's Beating Cancer Plan. It's the most important plan at the European Union. Now it's becoming to the end. Now cardiovascular would be probably the new one. Do you know how many times patient safety is mentioned in that document? 0. Not a single one. So patient safety does not exist in European Commission, not at all.
This is a misunderstanding. I mean, you know, it goes beyond just doing something, maybe having technical support or something like this. Sometimes to the extreme, it might be more safer for the patient not to have surgery done.
Yeah, absolutely. Yeah. But this is avoid unnecessary surgeries. But since the topic is not discussed, I mean, these elements are not part of that. So it's so let's trust that EHMA is getting success in that, and finally, you know, the European Union is launching, as Eleonora was saying, it could be one European strategy because, I mean, they cannot regulate on that, it's transferred to the member states, but at least a European strategy.
Maybe there's one more question, time for one more question.
Hi, I'm Daniel Arnal from Censar, and this time I'm going to ask, because and this is for José Luis Gómez, probably, or maybe the rest. But I remember it's a few years ago, BD actually developed an intelligent port to administer the intravenous medication that would recognize the syringes, and that could be linked to the electronic record. And this would really fit to what we are discussing right now, because in Censar, we did a review of all the incidents, 10 years of incidents in anesthesiology. And we had that the main issue and the main moment where the errors in medications were reported was during the administration. It's the moment where we anesthesiologists provide dangerous intravenous medications alone, without a proper supervision, with nobody else to check what we are doing. So that happens. But still, it's been almost 10 years since the first time I heard and even saw a video of this device, and it's not really reached the clinical opportunity for us to try to have it and test it and work with it. And I believe that would really make a difference, but there is a huge gap between the development of the technology and the availability. Can you comment something about this?
Well, I know the technology. I'm not really aware of what is happening with that technology, but so I cannot comment on that. But I can comment around this other solutions that the company is developing in the area of anesthesia to help you in preventing medication errors. So, for example, these medication traceability systems could help you as well in the area of anesthesia to ensure that the dose is the right one, you administrate the right at the right time to the patient, etc. But I cannot tell you more around Intelport or Intelliport. I remember I know a long story about that, but But I don't know what was behind, because I was in a different position before, so I cannot tell you. But yeah, I mean, it's a pity sometimes that development are not ending up in the day-to-day.
Maybe there are some more questions, but these questions will have to be there with you until the next break. Oh, my timer. I mean, maybe just to summarize, I mean, what I have heard is that there is a house that is on fire, and that is actually the house of patient safety. And you are actually that patient. You are in the house, but you're also the fire brigade. And that makes it pretty difficult. I mean, my learning from today is maybe just don't take the next surgery or don't take the next technology if you have not implemented the previous in a decent way, because otherwise you will further make your own employees and colleagues completely crazy. I want to thank you for being here and your attention, your questions, and of course the panelists for sharing their knowledge and experience. And I wish you a very pleasant rest of the conference. Thank you.